Hey guys, welcome to my video on how to admit a patient into Epic. I'm very excited to be bringing this video to you guys today because this is going to be an update to my prior video, except this time we're going to be completely in the practice environment, and so I won't have to blur anything out for you, and hopefully this will give you a very, very clear look into how the process of admitting a patient goes. So why don't we just get started? So here I have my current list of patients, and say we got called on a new patient that's in the ED waiting to be admitted. And so the first thing you want to ask for is an MRN, and I go up to the top left here and I hit the add patient, and then I'm going to add the patient. And at this point, the screening hospitalist or the ED doctor is going to start telling you about the patient. So I just like to go directly into the chart. And the first thing that I like to do early is just open up a sticky note. And whatever pertinent things they're telling me, I will basically start inputting here just to take some notes while they're giving me kind of the sign out. So, let's say they say it's a 70-year-old man, has a history of heart failure, diabetes, AFib, basically coming in with shortness of breath for 2 weeks, recently admitted for COVID, has been off his Eliquis due to some GI bleeding. Looks like he has some swelling and got some Lasix, 40 milligrams in the ED, and got some ceftriaxone and azithromycin for potential pneumonia. So that's basically what the ED told us. And so I have this little sticky note up here just for my own reference. And at this point, while they're kind of giving me that story, I'm also doing quite a few things. So I'm going to be checking at their vitals. Unfortunately, this test patient doesn't have any vitals here, but normally you would find a place where you could see their vitals and just make sure that this patient is appropriate for the floor. And they're not like an ICU level patient where they're super hypotensive or hypertensive emergency where their blood pressures are in the 200s. After taking a quick look at the vitals, I'm also really just going through their results, and I just kind of go through them one at a time. Really just want to make sure that there's nothing super abnormal like potassium of 6 or creatinine of 8 or 9, and the patient might need dialysis because their BUN is like in the hundreds. Just want to make sure there's nothing super abnormal that would make them unstable for the floor. So I'll also check their blood count and things like that. So at that point, I've done a quick review of the patient, and I've also determined that they're stable. So I have a little bit of time to do some chart review. And, the ED physician is hung up at this point. And so I'm just going to go ahead and start my new note right away. So I'll just hit new note right here. And then we're going to type H&P. And you're going to put your attending as a cosigner. And then you're going to put your dot phrase for a history and physical. Okay. And as I open this note up like this, I'm going to be writing things down while I chart review the patient. So chief complaint, shortness of breath times 2 weeks. And then so patient is 78-year-old male with type 2 diabetes, hypertension, hyperlipidemia, CKD3, AFib on Eliquis, has been off Eliquis for the past 2 weeks or something. And then, he's got heart failure, 30%. And so I'm not necessarily going to know that he has EF of 30% yet until I kind of have been going through all this data. And, I check on his echo and I open this up and I say, okay, EF is 30%. Basically, I'm going to be kind of populating my one-liner as I go through and review the patient. The other thing I like to do early is just go through the notes that are in the chart already. And so usually you're not going to have all these notes in here already. It's just going to be like 3 or 4 notes. Usually you're going to have the ED triage nurse note, and it's going to be a very bare bones, like what did the patient come in? What was their complaint? And then you're going to have sometimes the ED provider note that's down there where the ED provider has really kind of started with the history. So gotten a basic initial history for you and basic initial workup for you. And then you can see their thought process for why they gave the patient Lasix, ceftriaxone, azithromycin. And then as I'm reading those, I'll kind of populate this H&P with some of the data that I'm getting. So patient was recently hospitalized for COVID pneumonia, 9/1 to 9/10. He was discharged to a SNF. States that ever since then he's been having worsening leg swelling and shortness of breath on exertion. Symptoms have mainly worsened over the past 2 weeks. And then basically patient also reports productive cough and subjective chills over the past 4 days, something like that. So obviously as I go down to talk to the patient is when I'm going to add more details into the history, but I'm just kind of getting the initial basic history here. So before I go see the patient, I already have an idea and I've already started kind of writing my note a little bit. All right, and the other thing that I want you to practice doing is going into this chart review tab here. And what you really want to look for is kind of the last few notes coming in for the patient. If the patient is in this hospital system, you're going to be able to get a lot of really useful information, especially for anything that's in red. So anything that's in red is going to be another ED visit or a hospital admission. And one way, you can either scroll down and just kind of quickly glance at it, or you can even make your own filter where it's only going to filter the ED visits and hospital admissions. And these are really high yield because especially if it's a hospital admission, it's going to have a discharge summary. And that discharge summary is going to be one place you can really get a good one-liner for the patient, but also you can get some of the problem list that the patient previously had. So you're going to know, it's going to help you basically make your own problem list. And also you'll just see recent major events that happened, because obviously if somebody got hospitalized recently, that's a major event that happened recently and is pertinent to their medical history. So in this case, we can pretend that this admission here was his COVID pneumonia admission, September 1 to September 10th. And basically, I'm going to go through and just see what happened in that hospital stay, what they treated him with, and basically what his hospital course was like overall. And besides that, it's usually good to look at the last couple of outpatient visits too, or outpatient notes, just to get a general sense of the patient overall. But definitely you want to look at a couple of the most recent admissions to see what's been going on in the patient's life. At this point, you're pretty much ready to see the patient. I will say that sometimes when I'm doing admissions, if I'm just going through their labs and I see like really glaring abnormalities and I want to remind myself I can put it here. So like say he had an AKI and I'll say creatinine 2.5, baseline creatinine 0.9. You can start putting stuff like acute on chronic, decompensated systolic heart failure, EF 30%, and you can start putting like information that you start finding, like their dry weight, their home regimen, and then you can even use your dot phrases if you have any. This one's kind of not updated, but basically this like helps me remind me of like all the stuff that we should potentially do for a decompensated heart failure exacerbation. All right, so I just basically randomly filled this out, but I'm not going to really write this much beforehand, but sometimes basically my point is you can get some of the initial part of the assessment and plan written before you even go see the patient, and then when you go down and see the patient, you'll have a better idea of what your initial plan is, and then you can go and change it. Obviously, I wouldn't spend too much time doing this before you see the patient. It's usually more important to just get the history from the patient. So that's just basically my quick little 2 thoughts on that. So the next step is to go down and see the patient. And so when you're seeing the patient, you're going to be interviewing them. And when you're the intern, usually you're going to be taking the history, and hopefully your senior resident is going to be scribing for you or helping you put in some initial admission orders. But I did want to go over how you can actually do the admission orders and how you can actually, reconcile their medications and everything. And all of that is going to be in this Navigators tab here. And this may vary depending on your own institution. But here you can see the first tab is going to be the history tab. And here you want to keep this updated, right? So say this patient, we're going to remove some of this stuff that, he doesn't have, at least in our example case. So let's just take out anything that really doesn't seem that pertinent. And, we're going to add heart failure with reduced EF. And you can add a little bit of details, EF 30% or whatever you want. And then you can say AFib, things like that. And so that's how you can update this. And this is really nice to have updated in the system, because when people pull up the patient later, all of this stuff is going to auto-populate into their notes. So I personally do like to keep this stuff updated if I can. And then obviously if they've had some surgery recently, okay, well, this guy's already got an appendectomy, a gallbladder removal, and tonsils removed. So that's enough surgeries. We can keep that. And you can update the social history, which is like how much they're drinking and smoking. If you actually go up to this history place and you go to social documentation, I also like to do this social documentation here, because this will also really update in a lot of people's notes, at least in our system. So I'll write down where their residence is and kind of all this stuff. I'll freehand it in there, and it's like just a really useful way to update the chart for people in the future when this patient needs to be admitted again. And then family history, obviously you're going to update that as well. So mom had hypertension. Sometimes you got to type it out actually fully. And dad had MI, and his brother had a stroke or something. And so, that's how you can update that. Then you want to go down to this review current orders. And this is going to be all the orders that are in the ED and that you want to continue or discontinue. So this is obviously going to be more than what's normally in here. Normally there's just a few things in here because the ED only places a few orders. But so say, I don't want to continue these. Obviously, this patient's not on Levo or propofol. And usually I'll continue most of the stuff the ED has, but in this particular case, it's like a bunch of inpatient stuff that we're going to be putting in. So I'll discontinue all this stuff. But usually in the ED, it's something like a bed request and maybe like some imaging and blood cultures. So I would hit continue on all of those. When you're down there, you also want to be reviewing the patient's home med. So this is how you do the med rec. So this is really helpful to pull up while you're talking to the patient. You just go to this review home meds place, and you'll see, hey, are you on Flovent? Are you taking this Bactrim BID? And he says no. Are you taking lisinopril? Remember, our guy was taking lisinopril, so he says yes. So we can add that in if it's not here already. So lisinopril, 20 milligrams. And so that automatically adds it here. And you can see that when they're taking it, you want to check this box that says they're taking it. So let's say he's taking lisinopril, and he's taking Pepto-Bismol and albuterol inhaler. And let's say he's also taking his metoprolol. And then also he is taking the Eliquis. But remember, he wasn't taking it because for some reason he wasn't taking it, so we'll just uncheck that there, but we'll just add it to his medication list. And then you want to hit mark as reviewed here so people know that you actually took a look at this. Basically, at this point, you've probably finished your interview with the patient, and so you're going to go back upstairs and start putting in the admission orders. And so the next tab after that you're going to go to is the reorder home medications. So here, you want to choose if you're going to suspend or continue certain medications. So in this case, we'll keep him on his lisinopril. It's okay to continue during an exacerbation, a heart failure exacerbation, as well as his metoprolol succinate. We're not worried about him going into cardiogenic shock or something, so he can continue this. And then we don't want him to be on this Bactrim or this warfarin or any of this stuff. And let's just take off this Pepto-Bismol. We're not holding his Eliquis because I guess he was having some GI bleeding or something and stuff like that. So this is how you kind of go through their list to just determine what you want to order. And you can see that automatically it's going to order some of these medications for their hospital admission. Next, you go to order sets. And for us, you're going to see all of these admission order sets. And you see here, there's a IM acute care admission. And this is for my hospital, but you can go to this. And then you can also actually make your own custom version. So if there's any particular things that you're frequently choosing or selecting, then you can actually save it into your own custom admission order set, and so that you don't have to keep clicking on those in the future. But for the purposes of this demonstration, we can just go to the original order set, and I'll just show you how to go through this order set. So open this order set, and it sometimes takes a little bit. All right, so this may look a little bit different. I think this patient's already admitted, but normally there's going to be something up here that says admit patient, and then you'll say admit it under attending X, and then admit to med surge, and basically how long you think the patient's going to be here. And then for your patient condition, you usually have the choice of critical, fair, good, or serious. I usually just like to type it here because I know what they are. So if you type it, it's a little bit faster. And one little tip is that you don't have to go down to the accept every time you want to accept something. You can just right click anywhere in this box and that'll close it. And that just makes clicking through all these boxes a lot faster. Suspected infection, you can use this if you think he has C. diff or something, but if you just leave this checked and you don't click anything here, it doesn't do anything. So I usually just avoid this part unless I think there's something going on, because this will initiate all the contact precautions and all that stuff. Next, we have a would you be surprised if the patient died in the next 6 months? And this basically just flags the patient, so a social worker will come talk to them and make sure they have a pulse and advanced care planning stuff all completed. If you would, so just fill this out appropriately. If you do write the no, I would not be surprised, then the social worker will go see the patient sometime during their admission. Vital signs, we're going to click here. And you're going to determine if you want it every 4 hours, every 6 hours. The most you can do on the floors at my institution is every 4 hours. But obviously, if a patient's more stable, I usually do every 6 hours. But he's just coming into the hospital, so let's do every 4 hours. We'll get wait once now, and we'll get wait once per day. This one, you really got to sometimes make sure the nurses are actually doing, because if it's default ordered for every single patient, they don't necessarily do it unless you really make sure, this patient's here for a heart failure exacerbation. We want to make sure we get a daily standing weight. And then intake and output every shift. This is notify house officers. So there's some parameters for when they should page a resident. And so sometimes you have to make a dot phrase for this. So let's see, mine is dot parameters. And that pretty much was the same as what they had over there. I basically always click this may transport without telemetry because otherwise the nurses will page you and be like, hey, can you put a may transport without telemetry order? Because otherwise they can't move the bed out of the ED half the time. This restorative sleep standard is basically like minimizing vitals checks and lab checks like in between 10 and 6 a.m. And then nursing to assess mobility to see if the patient can be mobile on their own safely. Here's Foley catheter if you need. A shower I always check. So this patient, we can just put them on a low sodium diet. Start with a late tray. If they have diabetes, you could just add carb restriction here as well. And then if you wanted to do a fluid restriction, you could do it here. So you could just do like 2-liter fluid restriction. Evidence not that great for heart failure actually, but it's obviously a very common practice. And then here I like to usually like to get pulse ox with vitals. So this just means they're just going to check their O2 sat with vitals. But if you really were worried about somebody's oxygen status, you could do pulse ox up here, and you could do pulse ox continuous. So, with this one, you could probably just do with vitals, but, either way, whatever you want. And then oxygen therapy. So this patient's on nasal cannula, so they're going to need this order. So you can just do this and just give them a nasal cannula order right there. If somebody has sleep apnea, then you can order the CPAP here for them. Fluids you got here. And then obviously this patient, we're not going to order fluids, but I just wanted to go over really quickly that if you do order fluids, you really want to put a stop or an end time to it. So let's say a patient comes in, you want to start them on some maintenance fluids. This is just going to continue running forever. And this is a big problem on the floors, especially I think with services that don't do as much admissions. They can get patients really, really volume overloaded. And so what you want to do is really set it for like 12 hours. So it's going to discontinue. And that it's not just going to continually be giving this patient fluids and they're going to get super volume overloaded. So always set an end date to any of the fluids that you're going to be ordering for your patients, or just do boluses, which is also another easy alternative. Over here, I like to do pain management. So it gives you their creatinine. So you can choose pain management regimens based on their normal renal function, moderate, or severe renal impairment. So if we do normal renal function here we've got some non-pharmacologic treatment options. And then I basically always put the patient on PRN Tylenol. Otherwise, your cross-cover person or you are just going to get paged eventually because there was no PRN Tylenol ordered. And then you have opioid regimens here and bowel care. So if anybody's on an opioid regimen, make sure they're really, really, definitely you want them on a good bowel regimen. Here's another section that has the bowel care. And usually, I have people on Miralax basically by default for everybody. And you'll see that they'll hold it if there's any loose stool or diarrhea. And then they can get a PRN bisacodyl. If I'm really worried somebody's going to be constipated, I usually just add like Senna, 2 tablets at bedtime. But initially when I was an intern, I had everybody on Miralax and Senna. I think maybe that's probably a little overkill. You could probably just give somebody Senna, just be a little more gentle with it. And then give them this melatonin at night, every night. I actually usually like to just schedule it instead of being bedtime PRN. That's just because it's really hard to sleep in the hospital, and melatonin is just a very low risk thing. And so, I feel like patients aren't necessarily going to know to ask for it if it's PRN. So just make it scheduled is pretty nice. By default, you've got some antiemetics ordered, which is really nice, and some anti-itching for any skin rash that they might have. If somebody has a smoking history, then you want to order this smoking cessation, and then also nicotine replacement therapy. So say this person's like smoking a pack per day, which is like 20 cigarettes a day. So we'll give them a nicotine patch, and it basically gives them the patch plus PRN, which is the best evidence-based way to kind of make sure they don't withdraw or have really bad cravings and symptoms in the hospital. And then automatically it's going to order some SCDs just for DVT prophylaxis. And then we're also going to go into pharmacologic VTE prophylaxis. So in this case, this patient was on apixaban. And so if you continued, if they were going to continue that in the hospital, you would just click this. They're already on therapeutic anticoagulation. But in this case, this patient was holding it. And if somebody's bleeding a lot, then you're just going to hit this VTE prophylaxis contraindicated. and you say due to bleeding. But generally, I would say for pretty much 95% of patients, you're just going to hit this moderate risk VTE, and you're going to put them on enoxaparin or Lovenox. And this is going to be basically all your patients, unless they have really, really bad kidney function or really bad AKI. Then you'll do the heparin, 5,000 units every 8 hours. All right, so let's just say we put this patient on Lovenox 40 every night. And then we're going to get labs. So CBC with differential, yeah, we're going to get that in this patient. And I always like to remove this. So in my custom order set, I just have this removed in general, but I remove the 3 occurrences. So that way it's just ordered indefinitely. Patients often don't need daily labs, but for medicine patients, a lot of times they do need daily labs. So, I just remove this so it doesn't accidentally fall off. So just turn off all the occurrences here, and then it will just continue until specified. And then, what you should do really is just kind of look at it every day and see, does the patient still need BID labs or something like that. All right, so we ordered CBC every morning, BMP and MAG twice a day. And then, none of this stuff. We can get a hepatic function panel like right on admission. Usually the ED sends off a UA with culture already. And then urine drugs of abuse screen. If you think there's some kind of risk that they may have done some drugs, you can send that. And then you can send some iron panels. So I have my own iron panel that I've made, and then it basically sends off everything that you need: iron, ferritin, transferrin. And then you've got chest x-rays, EKGs, say you want an echo for him, you want physical therapy, and then just say assess mobility needs, anticipated to discharge in greater than 48 hours. You can get occupational therapy if they have some more like DME needs, or if they have smaller, problems with completing their ADLs. And then all these other consults here as well. And that's basically it for the admission orders. And so after that, you've got all of these orders basically all lined up here, and you can just sign it and basically admit the patient. All right, and patient is now admitted. After that, I like to just quickly go to the orders tab, just make sure all the orders look like the way I like them. And then I'll just start adding any additional orders that I think of after that. So let's say, okay, let's do Lasix 40 BID for this patient now. And let's continue the ceftriaxone and azithromycin, because it seems like, he did have a little bit of like a productive cough and some fever. Like he started spiking a fever in the ED. Okay, so we'll do basically this right here. And this is really, this isn't really a realistic patient example, but I'm just kind of showing you how I would, order some certain things, just so you have a reference. So you have to like do all this stuff here, which is a little annoying. And that's pretty much it. And then throughout the day, you'll start thinking of more things that you want to order. But basically, you've gotten the main orders in for this patient. After that, just go and finish your note. One thing I do is refresh it, because it's going to automatically refresh all that stuff that you edited, as well as their medications. And then you can update all the social history and stuff here. Lives in Sacramento, retired construction worker, 1 pack per day for 20 years, none currently, or like whatever you want. Okay, and then your physical exams here. So pleasant, elderly man, no acute distress, JVD elevated to 9 centimeters. CV is irregular, normal rate, crackles bilaterally to mid-lung. And 2+ pitting lower extremity edema bilaterally, something like that. You could also have done like a POCUS, shows dilated IVC with minimal respiratory variation. Micro, COVID 924, COVID negative. And then here you'll do chest x-ray, 924 chest x-ray, and I'll just go in and I'll find that chest x-ray, and then I'll just put in the impression. So usually I'll copy paste it, but it'll say bilateral pulmonary opacities consistent with pulmonary edema. And then here I will, post basically all that stuff that I was talking about over here. I'll finish out the assessment and plan. I'll fill out all of this stuff here. So patients on Miralax, no ulcer prophylaxis, thromboprophylaxis, you're on Lovenox. Oh, and this is Fast Hugs BID for like a ICU patient. So this is a little bit different than what we need. But yeah, I'll just update all this stuff. And that's pretty much my whole process. I'm just going to finish the note and patient is successfully admitted. So please let me know down in the comments if you have any questions about going through the Navigators tab, updating all of that history and going through the admission order set. Hopefully this was useful for you guys, just seeing somebody do an example admission. And like I said, let me know if there's any other questions you have or other videos you'd like me to do. I'd love to make more videos to help you guys with this. We're going to talk about how to discharge a patient. And then also we're going to talk about how to use the results review a little bit more effectively as well. So thanks for watching. See you in the next one, and peace.